please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
And when you're in a course and you're having so much fun and you're surrounded by brains that are going to do amazing things with FSM, it doesn't matter what the weather is like outside. So I'm glad that people have had a good time with us. We have a bit of a live studio audience. People who have been in my course for the past 3 days are here with us live on the other side of this camera. But I have so much fun teaching, more fun teaching than I do attending. Because I like to talk and I like to move. So that's very helpful, because when you are a participant, talking and moving is frowned upon.
And I got to teach a 2-day practicum over the weekend, and we had 17, 18 people. And so it's the nice thing about having small classes and about not having to get on airplanes and ship stuff.
Yeah.
Is we're at home. And the practicums over the weekend were magic. You know how the supine lumbar practicum is always fun anyway?
Yes.
This was 2 practitioners on separate tables with intricate, complicated, difficult abdominal surgeries, one of which looked like it was done with a chainsaw, but that's another conversation. And to watch them learn how to press, find the tight spot, wait while it softens 1 to 2 millimeters, and then stretch it for 1 to 2 millimeters until it gets tight again.
Yeah.
And then wait. Getting to go through the manual part during those practicums was just a game changer for the students. And then for those that stayed for the rehab portion and then the sports advanced,
Yeah.
it's just like 5 days of awesomeness.
It can be overwhelming though. So I was thinking about, I had somebody that contacted me a couple weeks ago and said, I'm really interested in FSM. This is a busy chiropractor. How will FSM change my practice in 2 minutes?
Go. I said, how do you
explain? I don't know. I said, I can't summarize that in 2 minutes. And I said, no, how will it change me as a practitioner? So it will.
How do you say that?
The questions kept getting more and more complicated. So those of you who are listening that are practitioners using FSM, you understand this tongue-tiedness that it caught me in. I know that it will make you a better person. I know that it will make you a better practitioner. I know that it will challenge you. I know that it will infuriate you. I know that it will give you hope. These are all these things that I could think of.
I'm a lot more specific because specifics give them something to grab onto.
Yes.
So there's one of the short versions and the things we take for granted. So I had an MD as a patient last week who was an internist, retired, and then his wife. And his wife's pain diagram was interesting and suggested that it was abdominal adhesions and trigger points, it was trigger points in the psoas, the rectus abdominis, and the quadratus lumborum. And so he watched me work on the psoas, the rectus abdominis, the quadratus lumborum, and he said, this is like impossible. And that's the short version of what I would tell a chiropractor who said, how will it change my practice? You'll be able to treat things you've never been able to treat. And he'll say, what? Have you ever in your life been able to say treating nerve pain is easy? So the patient comes in with a lumbar disc and level 7 pain at the L5 and S1 nerve root on the left. And in 15 minutes, their pain is a 0. Can you do that now? With FSM, nerve pain is the easiest thing we treat. Repairing the disc, there's a protocol for repairing the disc. And you tell the patient, we get rid of the nerve pain. You come in and see me, or you can use a home unit to get rid of the nerve pain. And then we run a protocol 2 or 3 times a week for 6 weeks. Your disc bulge doesn't have a fragment. It's just a bulge. And it's like having a sprained ankle in your disc.
Somebody just wrote, can we look at the other camera? We see looking up at the ceiling.
Oh,
So
I-
we're not supposed to look at Kevin's camera anymore. I guess
We're
looking
not
at
supposed
this
to look at Kevin's camera. Thank
According-
you, because I
according to-
don't like looking at Kevin's camera. I like
According
looking at
to
this camera.
Thank you, Anonymous.
Thank you, thank you, Anonymous.
Okay,
Anyway, so
Anyway.
that's the specifics. Is nerve pain is the easiest thing to treat. Treating traumatic brain injuries, treating the vagus nerve, treating gastroparesis, Ehlers-Danlos, sprain strain injuries.
do you know what I caught myself saying today?
What'd you say?
Showing how easy frozen shoulder is to treat.
Oh yeah, that's
And I had that moment where I'm just like,
waiting for lightning. Yeah,
and not every type of frozen shoulder, we were talking about the differences between pathological or disease frozen shoulder type 1 versus secondary frozen shoulder type 2. And how we-
Scap,
But when the onset is because of something like a hormonal imbalance or an autoimmune imbalance or a vaccine injury or stress, and what does infection, stress, and trauma have to deal with? The vagus.
that Vegas.
So treating the vagus first before subscap can be happy. So it's giving the options, right? So as an instructor, I feel like the more options we can give.
It's why I love practicums.
Yes.
So we did the supine shoulder, and one of the practitioner was a chiropractor. The patient had an acute, subacute, like week or 2 old, where she did something. And so they started to treat the subscap, and her shoulder just wouldn't tolerate it. And I said, do me a favor, feel the back side of her shoulder. And you could feel the dent where the infraspinatus and the teres major and minor, there was he said, yeah, it's dents in. I said, yeah, there's an innie where there should be an outie. And he went, okay. So we switched. I said, so what kind of attachment do those tendons have? Connective tissue. Okay. So what is the frequency to repair torn and broken, or to repair and heal? 124. And then what's the frequency for connective tissue? 77. Okay. So put that on and just keep your fingers on and feel what happens. So I circulated around the other tables, and I came back and I said, what's happening to the innie? And he said, it's filling in. Yeah, give it another couple of minutes and then you can work on the subscap, because the reason those posterior tendons have partial thickness tears is because the subscap is glued, and it was just impingement. So once he got the tendons to fill in, then he got the subscap loose. And I said, then what is impingement? It's bursitis and supraspinatus tendonitis. What are those frequencies? So that's the fun part of the practicum, is putting the kinesthetic input to go with the cognitive stuff. And then when they get to the rehab course, and I really have slide envy. You should see her slides. It's worth coming, not just for the educational magicness
Pretty slides.
and the Kimness. She has really great slides. You guys, yeah, definitely. Mine are boring, but I'm kindergarten. She's middle school and college. Well, middle school and high school, right? And a little bit of maybe first year.
Yeah,
Yeah, it's the next step.
I see slides when I go running. I see pictures and I see images, and I was making fun of one of my slides because one of my kids said, did you make that slide, Mom? And I said, yeah. And that's supposed to improve clarity because it's really confusing.
Sorry.
They don't understand the bubbles. So I think like anything else, we talked about the sacrum a lot today and sacral mechanics and sacral torsions, and you're very neurocentric. I'm very pelvic centric, yet both of us from our different backgrounds and love affairs with different systems.
I'd say you're more myocentric, right?
Yeah.
Myocentric, neurocentric, nerves move, muscles move bones. Nerves and muscles have to work together to make everything work.
Correct. But my starting place would be pelvic assessment.
Really?
Yes.
Cool. Why?
Because the osteopaths of before
Ah.
were very pelvic centric. And I feel like osteopathic models have disciples very much like chiropractic has the same sort of philosophy, and naturopaths and functional medicine doctors have very similar disciples. So to me, the spine and the sacrum are very good indicators of change. And so I wanted to give people some assessment tools, because sometimes smush can only tell us so much, and to have landmarks and markers to be like, this is changing. So sometimes the pain doesn't go away, but sometimes the structure changes, and sometimes the structure doesn't do much, but the pain goes away. So it's nice to have objective findings.
And if you look at the pelvis connects the legs to the spine, to the neck, to the skull.
Yep.
And the pelvis forms the platform for your relationship with the earth.
Ooh, that's very, it's very insightful.
Kind of
I like the way you
is,
said
right?
that.
It's kind of like you have to, so when we completely change the psoas, the hamstrings, and then the ankles, and teach somebody to walk again, my goal is by the 5th or 6th time they walk up and down the room, I want to see arms moving, shoulders moving, a little salsa music in their head. And that all has to happen at the pelvis and the SI joint. Yeah.
So we talk a lot about when an SI is stuck. And so I'm going to bring in your question here a little bit that we got at the end of the class. So we talk about locked up SI. We've talked about sprained SIs. We talk a lot about frequency. I see the SI joint as just like a giant ankle. It's no different as far as periosteum and ligamentous attachment and cartilage and that joint surface. A lot of kinesthetic awareness happens. A lot of pain generators are near. But when an SI joint is hypermobile, how do you assess for an SI that moves too much? And what frequencies would you think of if you thought there was not enough stability there?
The SI joint, I do this with my hands, right? One rocks back, one rocks forward. If this one's hypermobile, it's hypermobile for a reason.
Right.
So it always goes back to what happened? How'd you get there?
Yeah.
So what happened before? I was skiing, I was whatever. So this one can get hypermobile because you landed on your butt as you fell off a horse, landed on the stairs, did whatever, and just sheared it. Or this one can be hypermobile because you had a kidney infection or a kidney stone. The psoas turned to plywood on this side and locked this one. If you're going to walk, one of them has to move.
Right.
You only had a kidney infection on this side, the left side, and the brain says, okay, this one has to move. So muscles move bones.
Mm-hmm.
Nerves move muscles, muscles move bones. The SI joint didn't, unless there was a specific injury in shearing or one way or the other to the right SI joint. Though you have to look for why the right SI joint is hypermobile. And if it's because the left SI joint is locked because the psoas or the hamstrings or the pectineus and the brevis, if you look at everything that attaches to the one that's locked. So pretty much I don't check the hypermobile one first. I check the one that doesn't move. Why doesn't it move?
Right.
If there's an injury where they landed on it and sheared it, then okay, then you treat 124 and 77 and 124 and 100 and get this one to be more stable. That's pretty easy. Getting the locked one to move, I'm an activator chiropractor. Side posture adjusting is too dangerous in the lumbar spine and SI joint as far as I'm concerned. But then I tell everybody I'm a terrible chiropractor. Anyway, so that's my SI joint story, is what happened. So we had a practitioner during one of the practicums. She had a disastrous surgery that included a suprapubic catheter. So they put the catheter above her pubic bone into the bladder. Look at the anatomy in your head and tell me what's going to happen to her pelvis as a result of the fact that the catheter kept getting pulled out and she was bleeding into the femoral nerves, the femoral artery, the femoral veins, the pectineus, the brevis, and the bottom end of the iliacus and psoas. Just so every case is going to be different. What do you work on? It depends, is the answer.
Yeah. SI can be really tricky because a lot of the times where the pain isn't where the dysfunction is.
I would say, okay, almost always.
Okay. See, you're my like more confident voice here. Where
Well,
you're my definitive voice.
I've been doing this for 30 plus years.
And you must have started when you were
The-
5 then.
No, the pain is usually in the hypermobile segment, but muscles move bones. So you're checking obturator internus, adhesions in the nerve. So if you have a bleeder that happens to go down into the pelvic floor and you have an adhesion up in the ischial tuberosities with the obturator internus nerve and muscle, it's what's the cerebellum going to do to protect that nerve? The answer is always, write it down, just take note. I know you have pens. The answer is always in the history and the physical exam. See?
I'm thinking back to when we were in Kona 2 years ago and I was having pain in my left SI.
I love that.
You
Tell the
love it
story.
because you fixed it. Tell the story.
Tell the story.
I was having chronic pain in my left SI. I was getting my low back adjusted, my SI adjusted, but all they were doing was adjusting the left SI. So to your point and to my point, but when it's ourselves, we don't always think that clearly.
I can't even tell you.
I was just my own worst patient saying, my pain is in my left SI joint. You took 2 seconds and you were like, but why is your right stuck? Your left is hypermobile. What's going on the right?
Yeah.
Which brought you through to treating my appendix.
Appendix, psoas,
my rib cage, because I was an asthmatic teenager.
you skipped the QL, so we got the kidney and the
Yes.
fat pad.
Yes.
And then the ribs were supposed to move
But they didn't.
and they didn't. And it's, did you have bronchitis, pneumonia?
Can you remind me how you got to my appendix? Oh, we were doing
'Cause the
standing,
psoas.
no, we were doing
Oh.
standing hip flexion and I was testing, you wanted to see how I was moving. So just standing, doing hip flexion. And I noticed I could not flex my hip on the right as much. I didn't have pain, but it just wouldn't go.
Right.
And you thought, what is in the way of flexing your right hip?
That's right. That's right. And now I remember.
See how smart you are?
And it was like, you flex your hip, it stops. What is the cerebellum trying to protect? So I put my fingers down just above your pubic bone in the right lower quadrant, and there was this pesky appendix. You didn't have it removed, but when they took my appendix out, they said, wow, you've had appendicitis at least 6 times. So you think you have the stomach flu, you get abdominal pain and nausea and vomiting, and it's the flu. That's appendicitis.
That's amazing.
And so I had appendicitis and didn't know it. I never had appendicitis. They just took the appendix out when they went in to do something with an ovary, and it's like, "Well, it's here, I'll take it out." And what was wrong was the appendix was scarred to the peritoneal fascia and incidentally to the iliacus and the little nerves that go along with it. So
Who thinks like that? So I'm sorry, like without FSM, I would not have thought of that. Even with visceral manipulation training, I don't know if you think about that or you get there so quickly.
you wouldn't think about it, but the reason you wouldn't think about it is you don't have a tool that lets you fix it. It's like there is no way. So it's a 2-month project with a lot of discomfort and not much success to get the adhesions out between the appendix, the peritoneum, the psoas, and the iliacus. It's just like, how else can you do that? So that's what the other thing you tell somebody that says, how is it going to change my practice? You'll be able to treat things that you can't treat now. And that's why my favorite practitioners are the ones who've been in practice for at least 10 years. Getting them right out of school, they don't know what they can't do.
They don't know what you can't.
They don't know what they can't do because they think that what they taught them in school is going to work.
Right.
And it takes them about 10 years to figure out
We have
all that
somebody here in the audience that is just laughing because she knows.
didn't work. Yeah, it's so it lets you do the impossible.
Yeah.
And makes difficult things like scar tissue and nerve pain easy.
Right.
And then when he said, how is it going to change my practice? Number one, your chronic frequent flyers get better and they become your publicity agents.
Yeah.
And the way it changes your practice is you have to learn how to manage the flow of new patients. And that's
Right.
when that's when they stop and go, what? Every chronic pain patient you fix or help knows 6 people just like them.
Right.
So they go back and they say, hey, that guy I've been seeing once a week for the last 5 years, he got me better in 2 weeks. And now I just go back once a month or once every 2 months. So it saves me a ton of money. And it's this thing, it doesn't hurt. It's really weird, but it works.
Right.
Those 6 people and the person at the grocery store that knows them and the lady at the bank who wants your card, you have to learn how to manage new patients.
Right.
We got to the point where we had to take just 1 new patient a day because every new patient means twice a week for 4 to 6 weeks.
Mhm.
Even if they're better in 3 weeks, you plan on twice a week for 4 to 6 weeks.
Right.
And so you have to learn to manage new patients.
Right.
And then if they happen to have time after closing their jaw to say, how is it going to change me? It makes you think more and look at why. And it makes you patient and meticulous.
Mhm.
And what's the word, you guys, for the learning curve? Right? Where you're learning things and you do things that you're not sure you believe. And then you do them again and you get more consciously competent. So you go from knowing what you know, and that's every profession.
Right.
I can't think of a single technique that includes MDs, DOs, internists, cardiologists, neurologists, functional medicine specialists, naturopaths, chiropractors, physical therapists, occupational therapists, rehab doctors, athletic trainers, acupuncturists. Did I miss anybody? Nurse practitioners.
Probably a whole other group that we don't even know exists.
Yeah. So and then when you come to the advanced, you guys have to come to the advanced. It's going to be so cool. And the symposium, you're with your tribe. It's like FSM is like a family. You only get to keep what,
Oh, that is so great. And we were just talking about the generosity of FSM practitioners, right? It's not about proprietary information. It's not about ego first. It's patient-centric and it's patient care-centric. And if your MO is to truly listen, and that's how I think, how I've changed. I've slowed down, but I've gained so much more
Mhm. Yeah,
because I'm listening in a way that I never listened to. And it wasn't because I didn't care. It's because I didn't have any of the tools. And so I didn't ask the right questions because I didn't need to ask those
you didn't
questions.
ask those questions because it doesn't make any difference what happened the week before. There was a patient that came in last week or the week before, and we're doing this history. So her major complaint is anxiety. Okay. So we go back through, the whole timeline, and it's, oh my goodness, you have enough life trauma. And she said, yeah, but it got worse after I had whooping cough in January. Whooping cough. Wow. So I'm all ready to treat PTSD and concussion in Vegas. And because I have learned that I never get away with not doing it, I did the physical exam. You do range of motion, pokey wheel, reflexes, and put the tuning fork in the middle of her forehead. And she heard it only here. And I put the tuning fork on either side. Ow. Oh, eyes bounced. You have a vestibular injury. How did you get? She had no head injury. She had no thing. It got worse after whooping cough. I heard it, but I didn't get it until I did the physical exam. She had whooping cough. Anybody here ever had whooping cough or heard somebody cough?
No.
Think about the interthecal pressure that is created when you blow that much pressure up against the round window. It's just the round window, not the oval window, just the round window. And she's got endolymphatic hydrops on one side. And I ran 40 and 44, quiet the inner ear. Anxiety went away. I ran that for 30 minutes while I worked on her neck. That was it. She got up off the table a completely different person. The answer is always in the history and the physical exam.
You're right. And we talked about connecting the dots and then giving you and all of you new dots to connect. So it's taking, and we talked about this a bit in the rehab course, it's comparing the history and the present presentation
Right,
and the imaging
right.
and the previous diagnoses
And the physical exam.
and then your physical exam. And then it's putting all these bubbles, and my note taking is still pen and paper, and
Oh, me too.
I have to,
I hate EMR.
Yeah.
No offense.
so I have this little pad of paper, and on the top, it's my kind of exploration area. And then I divide the bottom part of my paper into A and B. So as they're talking, I start automatically writing A channel ideas
Oh, okay.
and B channel ideas down.
Okay.
And then Dr. Charlie Weingroff had talked about this so clearly when we talked to him on the podcast about these bubbles, right? So the patient presents in one bubble where they are today, and the imaging presents in another bubble. And sometimes what the imaging presents doesn't correlate to what they're describing, right? Somebody could be in excruciating pain and have very normal imaging. Somebody
Oh,
can
yeah.
be not in pain and have terrible imaging.
Mhm.
I have no disc between L4 and L5. Who knew?
And it doesn't matter because that particular thing is not the pain generator.
Right,
And that's a
So-
new concept to some people.
right.
Because this is so interdisciplinary, and because I hung out with osteopaths, chiropractors and MDs and acupuncturists and George and,
I told some George stories this weekend.
oh,
I love those
George
stories.
stories are like the best. Hi, George. And because it's so interdisciplinary, there's this cross-fertilization that happens when you treat somebody. So at the 5-day, we had somebody that literally could not bend her trunk.
Hmm.
Like it was straight, ram straight, and she could bend her neck, but she could barely bend her hips. And so we worked on scarring in the dura and got her bending forward and then bending forward and then scarring in the dura. And then eventually she was able to flex her trunk because you put your fingers in the diaphragm and have them bend forward over it. So it took about 30 minutes. And then as she's bending forward, I looked at her spine. And in my head, there's that diagram from, what's his name, this black acupuncture book. And there's the bladder meridian running straight up the back.
Hmm.
So I set the frequency as she sat up. I set the frequency for balancing 35, the bladder meridian. And I took my fingernail and just poked it on both sides, all the way up the spine to open up the bladder channel. Because if you're going to bend forward, it's not just the dura,
Right.
it's the whole energetic and acupuncture system.
And that's a whole other way of thinking of it. That
It's,
when did you like,
thank you, Pat Lawless and Sandra Megan, because when they came to take the FSM course in 2003, they do pulse diagnosis and spleen deficient, kidney deficient. And then we ran the frequencies for balancing kidney and spleen, and it wouldn't settle down.
right?
And then Sandra Megan said, the lung is the mother of the kidney. It's okay. So she wouldn't even tolerate vitality in the lung. We had to do balance in the lung, balance the lung,
And
kidneys,
using 35.
just 35. And the contact was behind her neck and under her feet. And you run balance in the lung, and the kidney and spleen just settled down. And she went from tired to perky.
Wow.
Who but an acupuncturist thinks like that?
And I think that's the wonderful like hive that we have, right? Is because we have practitioners that have their own special way of thinking of it. Like today or last 3 days, we talked heavy on agonist and antagonist. If the
Right.
primary mover is inhibited, this is how it shows up. If the antagonist is tight, this is what shows up.
Yeah.
But then you go ahead and just put a whole like truth bomb in there about meridians, and then
Well, it was the
and-
last resort because it's not my thing, but it was almost like
right.
you could see it.
Interesting.
So I poked it, and all of a sudden bending forward got easier.
Wow.
And then I thought of you, and we did 81 and 84 and had her contract segmental muscles as she sat up.
Right.
And the word I used because of you was stack it.
Yes.
Stack your vertebra.
We talked about that today, and I've actually been very careful with my words because of you, because we talk about this highly suggestible state that people are in with FSM. We don't want to use negative words. So we're changing the whole torn and broken to repair and heal. So the extra cue I've been adding to stacking is stack it like a Lego tower, something that is uniform and straight, like not like the Jenga tower that's about to, or Leaning Tower of
Mhm.
Pisa. So like stacking it, this is something that even if we're not kinesthetically aware of what our vertebra do, we can understand that concept of going vertebra by vertebra, stacking
Now all of a
blocks.
sudden it's making me sit up straighter as you
Right?
say
See,
that.
this
It's
is like
like
we're highly suggestible right
Yeah.
now. So we want to have good posture as we're stacking.
my
our
cerebellum
vertebrae.
heard you when you said stack it like a Lego tower.
Yeah. So this is all important. So it's not just about the frequencies, it's about, I think, our verbal cues on how to deliver that. So I'm not sure if there's any questions online yet. I'm not sure if
Haven't
there's
seen
anybody
any.
here that want to ask any questions, but typically around this time, my little timer goes off and I'm
Is it?
like,
No,
it's
it's
time for,
not.
no,
No,
it's
it's
not
20
time,
of.
but I normally do our check-in about halfway through.
Oh,
our
okay.
Q&A
Well, let's see.
questions.
I don't see any questions.
Well, we're just, wow, and there's
Are you
30
guys there? Hello?
That's very odd to not have any questions right now. but
That is.
that's
Apparently they're having so much fun.
Anybody here? We do have Yoda sitting in front of us. Now is chance to ask a question.
I actually have this, it was a sweatshirt it was a name tag and it had the FSM logo and it just said Yoda.
Okay, so we did that one year and you gave me one that said Luke. And then
That's right.
somebody had come up to me and was like, who didn't know, hi, Luke. And I'm just like, that's not my real name. These are our star warnings for this weekend.
That's the force, Luke. Oh my gosh.
Okay,
You don't have a list this time. Is that okay?
so
You've been too busy to make a list.
I don't. I have, again, it's an old school legal pad. And so I think Kevin said today is our what episode? 150.
Wow.
We've been doing this 150 times.
That's just crazy.
It just brings me, and there's never a shortage of things to talk about
Mm-mm.
because you get to debrief about your week. I get to debrief about my week. I could talk about teaching the courses. I have always all these questions. One question that comes up right all the time when I teach, and I always think I have to ask you the difference between 39 and 59 on B channel.
And the answer is for one weekend, I knew. One weekend. 59 and 39 are the frequencies for bone. One is cortical bone, that thick stuff on the outside. The other is cancellous bone, the fuzzy stuff on the inside. And there was a patient that had clearly damage to the outside part of the bone. And either 39 or 59 worked more smush, more heat, felt better. And that was that one time. And I didn't write it down. So
We run both.
you always have to run both.
Okay. Good.
I got one for you.
Oh,
Remember what we talked about the other night? The thing you don't want to talk about?
yeah.
Can I talk about that? Okay. So the thing that's difficult to talk about, and most of you, especially the people that are addicted to the podcast, are using FSM, and you get more and more complicated patients. And at some point, you're going to get a patient that breaks your heart.
Yeah.
Is that the best way to describe it?
Yeah.
It's surgery that went bad, a condition that can't be fixed, an emotional load for the patient that just breaks your heart.
Yeah.
And you can't fix it. You can empathize. My mother used to say, if you want sympathy, look it up in the dictionary. That's so sympathy doesn't do any good. Empathy is, I accept where you are and I don't, because if you put out that you want to fix it, number one, it's not fair if it's unfixable. Number two, then you put the patient, stay with me on this one, it's not easy. You put the patient in the position of feeling bad for being in the situation they are because their situation makes you feel bad. You got that? Is that right?
No, yes.
So empathy and collaboration. How can I help you? What is the most important thing I can do for you? I don't know, it'd be really nice if my shoulder didn't hurt. And then your take-home message the other night after our conversation was, you run concussion and vagus on yourself 3 times a week, at least. If that's the only reason you bought a magnetic converter, was that you could treat yourself in bed after you're asleep and it'll work even if you're sleeping. Because FSM practitioners as a group, because we have a tool that lets us work on the midbrain, quiet the limbic system, take a nap, honey, it's going to be all right.
Right.
At least temporarily, right?
Yeah.
It raises serotonin. It increases GABA, it decreases glutamate. It treating the vagus does all those things.
Right.
So we have a tool that lets us help the patient with their emotional stuff, but we get engaged.
Right.
And staying engaged and protecting yourself both energetically and emotionally, that's a balancing act that takes time. Took me about 10 years,
Wow. Yeah.
just so you guys know.
It's a very complicated topic,
You
right?
think?
But I think we can all agree, no matter if you're big into the energetic exchange or just being a practitioner, we talk about burnout all the time. We talk about proper body mechanics all the time, but the psychological burnout that happens when you start getting more and more complex patients, also the pressure that you feel when working with professional athletes to get the job done yesterday, it is a lot. We were talking a lot today about, no matter if it's an athlete or a complex pain patient, giving them as much control as possible so you don't feel as much responsibility to fix them, right? You are not the healer. So sometimes the conversation is, what do you hope to get out of treatment? Or what do you hope that we can achieve together? How can we collaborate in order to support your healing?
Yeah.
So it's not about necessarily even how can I help you? It's how can we work together? Would you feel comfortable with this sort of treatment plan that we collaborate on? We were talking about sending people home with custom cares and all the homework that they get to do.
The alphabet exercises.
Yes, alphabet exercises. But just saying, we are here together in the clinic, and this is what we're going to accomplish today together. And then when you go home on Tuesday, this is how you're going to help me when you come back and we work together on Wednesday. So it's the sharing of the responsibility, so you don't feel, like I said, all the responsibility to fix that person.
And it's not just that. What you do in the clinic sets the stage, but the patient has to create a stable state. And the stable state can be physical, emotional, spiritual, nutritional. Stable state is multifactorial.
Right.
So the patient with she has disc bulge at L5 and the bulge is sitting on the S1 nerve root. And it's okay, this is the exercise that you do. We got rid of her nerve pain. She went from a 7 to a 0.
Right.
And I ended up doing a disc pump, which is a chiropractic thing. And, oh, that does feel better. And then these are the exercises you do. And so there's a participation, and you do essential fatty acids, add that to your diet. And it's a collaboration.
Right.
And Leaf talks about therapeutic touch to add empathy and collaboration. Dora Kuhn's, if you look up therapeutic touch, it was Dolores Krieger and Dora Kuhn's. Dora Kuhn's was Harry Van Gelder's sister. So Harry set up sort of an adversarial relationship with the medical community. Dora went in the back door by training nurses to do therapeutic touch. And because the nurses were in the hospital, therapeutic touch is widely accepted.
Right.
And there's actually data on the energy spike. They put a therapeutic touch practitioner in a squid, which is a chamber that measures electromagnetic pulses. And when the therapeutic touch practitioner went into, it's in Jim Oshman's book, went into that therapeutic state, there was an energy pulse that blew the registers on the instruments, and they had to recalibrate it and set the spectrum wider
Wow.
for the receivers. Leaf, where do they get trained on therapeutic touch these days? Being that Dolores and Dora are both like gone.
There's got to be disciples of it, right? Because
Yeah.
it's widely accepted.
I just, no offense to anybody, but I just don't do Barbara Brenna's class, please. I've had to fix too many people that have been to that class.
Oh.
So there's that.
Okay.
But it's a matter of taking care of yourself, remaining empathetic. And the challenge with burnout is that there is a tendency to just get immune, and I just can't go there. I don't have the energy to do it. And that's a matter of your involvement.
Right.
And then a lot of times there's emotional stuff that the patient's dealing with. It's none of my business.
Right.
Right.
This is good to talk about because we used to talk about all the time doing like the physical barrier when in the days of the graphite gloves, because I have a couple really old sides that have the graphite gloves, and I remember my little spray bottle and my gloves and doing all the stuff. And but there was that barrier, right? So you felt, okay, I wasn't getting the current and until you couldn't stand the gloves anymore because you had to get your hands on the person.
On the skin.
So the question that comes up is, well, how do you block yourself from getting the current? And you don't.
No. During this 2-day practicum this weekend, there were 2 or 3 that were really sensitive to the current.
Mm-hmm.
And she gets us totally stoned working on somebody. And she said, how do you do this? And I said, number 1, you get used to working stoned.
Yeah.
And number 2, you become less drifty the more often you do it. So after about the first 3 months, it's not usually a problem. Right?
Totally. Yeah. You learn how to, like you said, work stone. And chances are, if you're feeling like that patient's stoned, so they don't notice that you're stoned, so you're both kind of stoned together.
Yeah.
So everybody's just having a moment.
Little dude effect.
I will get really warm, especially as I am doing something more and more profound. I start to get really warm.
If I'm doing something that's really profound is a good word, even if it's physical medicine,
Right.
I'll get tears in my eyes.
Mm.
It's not like I'm crying, it's just my eyes water.
Right.
And I get warm. That's pretty cool.
Yeah. And then you're right. You just learn how to work stone. So that's like we talk about the short-term play and the long-term play all the time with rehab. How do we, yes, you need to fix the ilia and yes, you need to break down scar tissue, but the short-term play is getting that patient out of pain. And then we can fix things. It doesn't matter if you fix the innominate rotation, if they came in a 5 out of 5 in pain and they left a 5 out of 5 in pain, they may not come back for treatment number 2. So we need to get the pain down. That's the short-term play. So our short-term play is, protecting ourselves and in the room and everything else. But the more you practice and the more those patients find you.
And the emotional interaction part is usually more of the long-term relationship. So the first visit, I have people create a timeline that goes back pretty much to birth.
Wow.
So my new patient visits are 2 to 3 hours, and an hour and a half to 2 hours of that is history. And then I've gotten so that I can do a pretty much complete physical in 20 minutes. And then the third hour is who has time to do that in the real world.
Right.
So you have them provide a timeline, look over it quickly, and then get to the presenting complaint. What can I do for you today?
Right.
And because the practitioners have them twice a week for 4 to 6 weeks. I have them for 4 days total. So I got to get stuff done.
Right.
I'm doing in 4 days what you're doing in 6 weeks. And so my approach to things at this point is different than the real world.
So that person who is in pain also knows that they're going to see you tomorrow. So
Right.
you get that. But I think for the most part, most of us don't practice in that model, and we want to get somebody out of pain.
You have to. You like the first visit, that's the goal.
Right.
And you treat the ureter and the psoas and run another machine to fix the SI joint that's unstable.
Right.
Use another machine to work manually on the one that's not moving. And then osteopathically or chiropractically or manual therapy, whatever PTs do, get the stuck one to move, and you'll get the stuck one to move by getting the muscles to let go,
Right.
and have a second machine that's repairing the loose one.
Yeah.
And it's 30 minutes, it's 60 minutes.
The other component to getting somebody out of pain, despite the fact is you want them to come back tomorrow, but if
Mhm.
somebody is in pain, is your treatment going to be as effective?
If their pain hasn't changed at the end of 30 to 60 minutes, you didn't do it. Didn't get it done. And in that case, I don't charge them for that visit. I just eat it.
Wow.
If you, it's, sorry, I'm just, and the receptionist says, what? That's okay, fine. I'll charge you $15 just so that we pay for the receptionist time, but I want to see you tomorrow
Right.
because I didn't get it.
We were talking a little bit today. I gave my own example of I had some shockwave done on my foot for a little plantar fasciitis ankle thing, and it was excruciating. And I was thinking about how much everything in every muscle in my leg was contracting, how I was pulling away and trying to yank my foot away. And it was this big, and I thought, this is the exact opposite of what a beneficial therapeutic treatment should feel like. The fascia, there's no thixotropic changes happening with biplanar fascia in
No.
that case.
No.
Everything was the thixotropic, maybe going the other way, going to rock solid,
Yeah,
because
it's like, get me out of here.
get me out of here. And my nervous system was hijacked and I started to sweat. And I'm like, this is not in the direction of healing in this moment.
Can you explain to me how shockwave has gotten so popular when it's that awful?
We were talking a little bit about shockwave and like the Theraguns and all the different percussive devices that are very popular right now. And I don't know if it was over COVID, people weren't going to practitioners, they were trying to treat themselves. I've been treating a lot of injuries because people are shockwaving and Theragunning tissues and inflaming them and making things worse, or damaging tissues because they're not being applied to the muscle belly. They're more in the musculotendinous junction.
Ow.
Yeah. And it's been,
Okay.
yeah, I've been treating a lot of those. So I don't know. I don't know why shockwave is popular, and,
Okay.
and some people like that more is more. I don't. John, did you have a question?
I just had a comment. I just wanted to say, if anybody hasn't come and spent 5 days, I just spent 5 days with these two ladies. And it's amazing. And what I wanted anybody out there in the world to know is I picked up 2 new frequencies that are in our book that I didn't know. And Kim taught this. And it was like putting in the good before pulling out the pathology. And it's like a game changer. So if you're not coming to these practicums, and Kim shouldn't be calling it the sports course, she should be calling it something else. It's vitality for
Rehab.
people. But
Vitality for
you
people.
can,
Vitality
you can
for
just
people.
do so much better. And I just picked up 30 years of wisdom in just 5 days. It was a
Oh.
bargain.
Oh,
Thanks,
thank you,
John.
John. That's real world.
That's a huge compliment. So yeah, and I owe that thinking again to the advance and listening to Roger Billica, and he was talking to nothing about frequency or physical medicine. He was talking it more on a prescriptive homeopathy supplement regime about sometimes you have to support somebody before you take out the bad stuff. And I'm like, that's what we have to do with fascia. We have to give the fascia thixotropic changes before we can pull out the scar tissue. We have to give strength before we could pull out. So that just changed my world. So that
You
is,
can do them at the same time. Can you do them at the same time?
I've tried, and sometimes it works, and sometimes it doesn't. And sometimes you just need to give the good. And
Did you learn anything new this week?
I learned so many new things.
Tell me. I want to learn.
Yeah. So as far as frequency or application or teaching or people or all of it,
Sure.
2 minutes. I have to summarize my week here.
No.
It's true. We have 2 minutes.
Oh, it is. Okay, go.
We learn we learn from our patients all the time.
Mhm.
And we learn, one of the things that I've learned is, as a practitioner with FSM, is I can't rush the process. And I'm learning as an instructor, I
We
also
shouldn't.
can't rush the process of teaching. that I have to give options. I have to give options to my clients. I have to give options to the students, but there has to be structure.
Yeah,
There has to be clear instruction, right? We're talking about that deep down. I am
Yeah.
a German Shepherd. I am a working dog. I
yes.
need a job. I need a job to do. Give me clear instruction and I will execute that job. However, we need to have adaptability.
Yeah, it's like educated intuition. You have to start in the first grade. Really, you have to know arithmetic before you can do algebra. So I'm the first grade through about first through eighth grade, maybe. And so you have to have structure. And then during the practicums, they learn flexibility. But you have to have a base to start from, but don't get attached to the recipe, right? Is that?
That's totally it. It's having a hypothesis that you are not attached to, and that's my alarm going off that it's,
That was the other
4 o'clock.
thing that FSM teaches you is flexibility of mind.
yeah,
You have to be flexible of mind.
yeah.
Don't get attached because some people walk in the room as students. You can beep away, but
No,
we're
it's,
gonna
it's
keep
my
talking.
phone over there,
Oh,
actually.
okay. They walk in their head attached to everything has an emotional basis.
Yeah.
It's no, yes, but no. It's, yeah,
Yeah. No,
your phone is gonna keep beeping until we stop talking.
it just tells us that it's, and now your
Okay.
computer's beeping and we're
It's-
all
that's-
beeping.
There we go.
But, oh, and we just got it shut off behind the scenes.
It's such a treat to get to do this in person. The next time we'll be in Phoenix.
Yes,
Yay.
we'll be in Phoenix and then there's the bigger ballroom and the bigger camera and the bigger questions and the bigger things.
Yeah,
So keep the cameras or keep the cameras rolling, keep the questions coming. I'm going to add it to my legal pad and maybe I'll bring it to Arizona so you guys can see after 150 episodes, just how much we haven't covered.
yeah, we have so much fun. Thanks for tuning in
Right.
or whatever your podcast, what do you call it when somebody listens to a podcast?
I don't know,
I don't know.
because it's not a radio.
Thanks
but
for hanging out with us for an hour.
I'm dealing with the
Yes,
camera changes.
there we
So
go. We got it wired though.
thank you. Thank all of you. And we'll see you all next week.
Do good things, change lives.
Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.